shapes and stirs up pharmacy. Welcome to PBM on the Rocks.
What do you guys do in your Hill Day?
We try to convince legislators to fix healthcare. No, just
How's
Really?
that working?
People do that?
not as well as we would hope.
Yeah.
So we, but through the Infusion Access Foundation, we bring our patient champions into DC and kind of run them through the gamut to get them empowered and ready to share their story in a Hill meeting. Right. It's one thing to be able to articulate your story, on the fly. It's another thing to be able to package and tailor and deliver your entire story in 90 seconds and still be as impactful as it was if you had 15 or 20 minutes is a challenge. So that's what we're trying to do.
That's awesome, Brian. That's so great. And it is a challenge. I know it's funny when you're saying that, because I was just thinking about a hearing I heard this morning in Florida. They're running a PBM bill, and it's one of those things that both lawmakers and people who testify really need to do better at. One woman she wasn't a lawmaker. She was so impactful, but she was going on way too long, and you could just feel it, right, as her testimony was going. But I've noticed the same thing with the lawmakers. They, and it's like it's an everywhere thing where they could just vote. They could just vote, right? But some of them have to be like, I'd like to explain my vote. And then they go on some unrelated tangent.
Long tangent.
Yeah. And then at the very end, they're like, and that's why I'm voting with the bill, or that's why I'm voting against it's just like,
and that's why I'm taking no action on this particular bill at all.
Yes, exactly.
Yeah. I'm sorry. What bill were we talking about again? Oh, I totally lost track. Yeah. It's pretty bizarre.
It is the worst. Jeffrey Lewis, you joined us. Welcome.
Stepped away from a great cigar to say hello.
Jeffrey connects philanthropy organizations with pharmacies to help get medications in people's hands.
It's a unique situation where we're able to just focus on parts of two different counties because that's how it was established. And then I spent a lot of time writing and helping out around the country on different healthcare issues and pharmacy issues.
Jeffrey, what is the name of your foundations?
One is called Legacy Health Endowment, and the other one is the EMC Health Foundation.
So do they both subsidize these programs?
Yes. So we generally spend anywhere from $2.5 to $3.5 million a year. We have an endowment of $70 million and growing, depending on the day of the market. It was created when a nonprofit hospital was sold to a for-profit. That gave it its original $35 million. We got a gift of $20 million from another entity, and been watching the assets grow since then. So it's a traditional private foundation, but limited to the southern part of one county and the northern part of another county.
Understood. How long have you been operating?
I'm the first president and CEO, so since June 1st, 2016.
Great.
That's really impressive.
So I'm very familiar with infusion centers and infusion in hospitals and 340B and private practice in that space, as well as how hospitals are making significant dollars in the infusion side, and physician offices are trying to figure out how to do the same thing with that much success. But
accurate. So I represent all of the non-hospital infusion centers.
Good.
Non-hospital oncology specifically. So
in the 340B space?
Yeah, none of which are eligible for the 340B discounts.
Unless they partnered with a FQHC.
A hospital, yep, exactly. A dish hospital as a child site, yep.
Yeah. Better off to partner with an FQHC where they're more likely to be able to share revenue.
Agreed. Yes. And I'm trying to basically figure out how to spin up a federally qualified infusion center model.
I'm happy to help you. It would be great to take one of your infusion centers in a probably more rural area, make them create them as a nonprofit, and then allow them to apply to HRSA as a FQHC lookalike.
Yeah, that's probably the best route. Huh?
By the way, that was my dog Boxer endorsing the two of you working together on
He is
this
very
project.
excited.
He loves this idea. That's all
Stay
that.
tuned for an
background
FQHC
translates.
lookalike near you.
So I thought it would be fun to play a game called Guess Whether Jeffrey actually used to work for a PBM or not.
Oh, I like this one.
Okay,
Shannon
let's
goes
play.
first.
All right.
How do we play the game?
You ask him questions and see what he says.
Oh, it's like 20 questions. Fun.
Yeah.
Brian, go first.
Okay. Did you work for a PBM?
Yeah.
Dude, that's cheating.
Bingo.
And Brian wins the prize.
You win the prize. It's a chocolate cigar on its way in the mail.
Which PBM did you work for?
It was a small regional PBM in Michigan.
Traditional PBM?
It was a traditional PBM that allegedly was a non-rebate PBM. And then as I spent more time and learned more, that wasn't the case.
Naturally, we're not a rebate PBM. And then the deeper you look behind the curtains, oh, that's exactly what's happening.
As I like to tell the story, I was hired as a chief operating officer, and then on the day one and second day, I didn't get access to the information I needed.
So, Jeffrey, what's your position on these new PBMs spinning up as rebate aggregators?
Well, the aggregators have been in existence for years. That's how many of these small PBMs who told you that they were either non-rebate or didn't participate would sell their data and make money. They're all tied to some aggregator one way or the other. Kroger's does an aggregation now in the Midwest. There's big ones and much larger ones that the Maxors, the Express Scripts, and others are affiliated with. So it's not a new model. It's just
okay. So I guess
go ahead.
This trend of pharmacists that are going from pharmacy to pharmacy benefit management as a rebate aggregator is then somewhat of a newer trend, or is that also not so new?
If they're working for a rebate aggregator as a pharmacist, makes more sense because they'll know how to leverage more of the meds.
So they've sold their pharmacy and have allegedly started their own
Aggregator.
Yeah, as a rebate aggregator.
It's
Sorry,
it's a tough
guys.
business to get in.
That's okay, Jeremy. It's an actual happy hour. And since it is the Cinco de Mayo version, we're just wondering, did you actually bring something with tequila this time?
No, I got some Corona Extra.
Oh, there you go. Okay.
Because my
Right.
after work
Excellent.
stopping by to get some tequila did not work out.
Excellent. Well, we didn't actually formally start off introducing our drinks, but I am drinking a Paloma. For those of you out there who don't know what that is, I'm sure everybody does though. It is a tequila with grapefruit juice. And tonight mine has a little bit of Grand Marnier on top, just because for some reason the tequila and the grapefruit juice didn't work as well together as I thought I did. I think I got my ratios off. So that's what I'm bringing to our Cinco de Mayo PBM on the Rocks trash session.
Nice.
Mm-hmm. Anybody else? Any other tequila drinks or Cinco de Mayo drinks or non-alcoholic drinks? Because remember, you don't have to have alcohol for this.
I have a water-infused pineapple essence hint water.
Oh, good. Excellent. Pineapple. That's a kind of Cinco de Mayo. Boxer says yes. Okay.
A little bit. I've
Brian,
got
what
a
about you?
Mexican Mule
Nice.
Oh, nice.
tequila, ginger beer,
Nice. I like it.
agave
Yeah.
nectar.
Perfect.
What have you got?
And I've got sangria.
That sounds good.
Oh, nice.
And then, of course, the big question, does everybody know what Cinco de Mayo actually celebrates?
Since everybody's
Independence is what I
looking
thought.
it up now.
Okay.
Brian, are you
So
Googling it?
it's that little known, no, it's actually that very big influential battle between the Mexican and the French in Puebla, Mexico, sometime in the 1800s.
Nice.
But, we figured, I guess, in our country, that would make an excellent day to sell lots of tequila and anything you can make with tequila. So we celebrate Cinco de Mayo. But one thing it's not, is it's not Mexican Independence Day. That's actually September 16th.
Honestly, there's something about our country that if it is a holiday in a different country, even a religious holiday, we find a way to turn it into a drinking holiday. St. Patrick's Day in Ireland is a religious holiday, but everybody here is like, green beer, let's go. So, I'm not sure how that happens.
Every holiday is a religious holiday in some form. And what are we supposed to do? Not drink on holidays?
Oh, you're supposed to drink on holidays.
Yes.
Otherwise, they wouldn't.
I'm a simple man. I do simple things.
Yes, you are, Jeremy. So we were just talking about this trend of PBMs and rebate aggregators. And Jeremy, you always have something to say about that. So what do you have to say about the answer to the question?
It's ridiculous. They find every way that they can to squeeze every dime out of anyone, or at least not let you get credit for the dime that you're spending, like rebate aggregators. It's ridiculous. It's always something. And once this all implodes, which it will because it's unsustainable, everyone's going to look back, and this is going to be this time in history where they look back on like rebate aggregators and all these things that we let people do, and we're going to look back on it like we look back on a lot of the early like monopolies, and we think, why didn't we know better? How did we not know this was going on? They're going to study, especially like rebates in general, not just rebate aggregators, in economic classes in the future on how you don't destabilize an entire industry because you give just a little market advantage, and they're going to morph it however they can and keep running into it. And now you got, Joey Maddington, whatever his name is, the Maryland professor. I was going on with him about all of that. I said, well, pretty much what we did was we allowed insurance companies to buy a kickback exemption. And he goes, Jeremy, I was going to disagree with you at first, and I thought about it, and you're actually completely right. Like, we just keep letting them do all this shit. It's ridiculous.
So this is really interesting because there's a trend that my members are dealing with right now. They're getting hammered by these new to market aggregators, right? And Jeremy, right before you joined, I was telling Jeffrey, they're pharmacists that sold their pharmacies and have started these pharmacy benefit managers, these organizations under the guise of a PBM. They can help extract rebates that my members have allegedly been leaving on the table. And an example they both use, they all are using ubiquitously, is this one massive cancer group in Florida that may or may not have a known history of fraud, Medicare fraud specifically.
Don't they all?
To unlock tens of millions of dollars in rebates that this group was leaving on the table. And so they're coming to the table with this massive carrot dangling in front of all of my members that are all struggling to resist that urge. And I can't help but feel like this is a way that PBMs will finally be able to get insight into what's happening on the medical benefit side of the market.
They already have that.
Yeah, they've had it for a while.
Benefit side, nowhere near the extent, but it feels like this is a way that they're going to be able to get paid by pharma to get data from infusion providers that they can extract more rebates, and then they can turn around and sell that aggregated data for additional revenue.
I'm not surprised. Every single one of them, they come and they're dangling them. It's always what they have on their back, and it's constant. Every time they try to give us something, it always turns around. Just like Express Scripts coming out today, acting like they're going to pay rural pharmacies more. And really what they're offering is more like, go ahead and do more MTMs and more clinical things, and we're going to give you more opportunities. We all know what that is. And whenever they dangle something like that, you have to remember every time that it's never worked out for us. It's never worked out for any of us. When has it? They just take more and more. So we can't trust them. and we have to stop doing it because they've taken over everything, and now they're taking over medical. Like that's their goal, to get too big to fail, to where the government has to work with them.
Yeah.
I mean, we have to stop it now or we've lost.
Jeffrey, you don't think it's a Trojan horse? You're thinking very deeply about that right now.
No, I think Jeremy's right. I think the PBMs have been in both the medicals. They've been in the medical side for a number of years, and the ones that are not talked about are the ones in the workers' comp side, where the PBM can really tell if a member is on workers' comp. They can help that employer guard against other drugs being filled that are not worker comp related. But they're going to get rebates from all those meds. So, the extent that they can grow their footprint on both sides, there's more dollars. The other thing that's been happening for a long time is why, you see the large PBMs buying insurers, whether it's Aetna or US Healthcare, because yes, to Jeremy's point, you're making money on every touch point. And then you turn those prescriptions into rebates, except for the hospital-based revenue. And that's where they'll get them. If they do, they'll get themselves what they dispense in the hospital. But just imagine that patient who leaves the hospital with 4 or 5 prescriptions. They just go downstairs in the hospital, they fill at the outpatient pharmacy. Now it qualifies as a 340B drug in a nonprofit hospital if they have a 340B vendor. And depending on what state you're in, depends on whether or not that hospital is playing both ends against the middle. If they're getting rebate dollars on one side and 340B dollars on the other side. And which is why California on the Medicaid side got rid of the 340B program. It's a straight, not a high dispensing fee, but a $14, $15 dispensing fee. So the state can aggregate all those claims and go after the rebate dollars themselves.
I actually had some asshole argue with me on Reddit recently over 340B. It was coming in just like, independents can make plenty of money right now. And I went, oh, the fuck they can.
Said the 340B hospital.
He came in, he was just like, well, I made this much and my pharmacy only does this much a day. And I went, those numbers don't add up. What the fuck are you talking about? And we went back and forth. I was like, you are a liar, sir. Well, it turns out that he owned a 340B pharmacy and didn't disclose that at the beginning. Jesus fucking Christ.
Well, he's going to make a higher dispensing rate, but he's giving up the spread on the drugs.
Oh, there's no spread on drugs anymore. That was given up a long time ago.
No, but that's where the other entity takes it for rebate purposes. So, it's the shell game. How do we move the dollar around to capture the revenue? But you're right. Yeah.
They've even got to the point where they have all of our buying groups and everything we can get back from those. They have it pegged. They have it dead on pegged. They know, they know all of our shit.
Yeah, AmerisourceBergen and Premier did that years ago.
Yes, they did. Amerisource sold out CPA, and I hope you hear me, Amerisource. Fuck yeah. Yeah, I hope we go elsewhere.
Has a way of just really holding back there. I wish you would just be more direct with how you feel, Jeremy.
Me? No, I'm
Brace your feelings, Jeremy.
Not Jeremy. No. Gonna be very indirect.
Jeremy's the only person I know who can drop an F-bomb 2 times in a sentence, but then still refer to the other party as sir.
Yes.
That's pretty good.
That is,
I know, it's a talent. It is such a talent. I mean,
I have to run off to a dinner, but I wanted to say at least hello and join the podcast. Look forward to longer conversations with all of you.
Thank you so much for dropping into the cocktail hour.
Thank you so much for including me. Take care.
Thank you, Jeffrey.
All right, thank you.
You have a good one, man.
So Brian, you were talking
Jeremy,
about
you scared him.
Yeah, way to kick the former PBM guy out of the Jesus. It was going so well.
He should know what he's coming into. I felt like I was being very tame today.
Oh my gosh. No, he's a very good sport. I may or may not have warned him about what this podcast was actually like.
So you may not have?
There's so much to be angry about, though. You're not angry, you're not paying attention. My
exactly.
gosh.
If you're not upset, you're doing something wrong.
No. What were you saying, brah?
I don't remember.
Yeah, the Mexican Mule is
Have
getting
some more Mexican Mule, Bri.
I feel like I have the attention span of a goldfish right now. About rebate aggregators, and I was excited to unpack that a little bit more with old Jeffrey.
Brian, did you say? I just want to clarify something you said when you were talking about rebate aggregators. You made the comment that pharmacists, independent pharmacists, are selling their pharmacies and going into this and basically going over to the dark side.
Yeah, say more about that.
What it sounded like. That is the context that was painted for me. Yes, is there were pharmacists that were tired of getting hosed by PBMs, so they sold their pharmacy. They started a PBM. So it started out with this one woman had this crazy concept, and she did it, and she made all of the money, sold that PBM to a larger national major name PBM, and now other pharmacists
start with 3 letters, would it?
I cannot.
Wasn't a 3-letter. Oh, you can neither confirm nor deny it.
I can neither confirm nor deny. Now other pharmacists have sold their pharmacies and have joined forces with her to start this new shop that I don't necessarily want to call out by name, but they have gotten very aggressive at approaching my members with this massive carrot. And it feels like this is the next evolution of tactic to get what they've always been trying to get, which is total insight and control over the medical benefit. They want to know where all of the rebate dollars are coming from, where they're going, who's using them, for what drugs, so they can really maximize value extraction out of the delivery channel. Feels like a way they're getting paid by pharma because they're keeping 30% of whatever rebates they're able to unlock. By the way, I left that little factoid out. So whatever dollars we are able to unlock for you, like you keep 70%, we get a cool 30. No big deal. Especially when we're talking about tens of millions of dollars. No big deal. You just give us all of your data, but don't worry. We'll de-identify it. We'll aggregate it with everybody else's data so it's safe.
No.
We're not going to tell you who with those data. Contracts aren't going to have any sort of data use parameters or guardrails. But trust us, because we used to be pharmacists. We're trying
like that.
We're the good guys. We're trying to help you guys just extract dollars. We're just called a PBM because that's what we had to call ourselves.
Wow.
That's still, I mean, I'm sorry. There, it sounds almost nefarious.
Yeah. Most people who sell, they sell and they get the fuck out. If you're waiting around, no, there's something else going on. That or they're just floating.
You just found some more juice to squeeze.
Yeah, I think the data is so valuable. It sounds a lot like, the Express Scripts GoodRx partnership, because that's all that is. It's just data. It's so easy to get so pissed off about that because, GoodRx has the money to go advertise themselves like there's some kind of good guy with the heart-wrenching, commercials. But really what it's about is it's about data, and it's aggregated, but that doesn't matter. Data is important. So I don't know. I kind of think you might be on to something, Brian. I think that they want to infiltrate. Like, were you around when Julie Hoffman was talking about the laboratory benefit managers? She talked about that so for people listening, Julie Hoffman is a really amazing patient advocate here in the state of Arizona for people with diabetes. And she showed up at a stakeholder meeting at one point and was talking about that the new PBM will be the LBM, the laboratory benefit manager, which is just one of those things that nobody knew we needed. I still don't think we need that. But
I don't think we need the pharmacy benefit manager, but that's just me.
I don't think we need health insurance.
And another concerning trend I'm seeing is the pharmacy benefit manager equivalent for employer plans, an employer benefit manager.
Isn't that just a reiteration of the same blooming thing?
Yeah, it's
Wow.
just another term for a third party administrator. Yeah, absolutely.
Wow.
Okay,
So
can-
one more middleman in the middle of the middleman, right? Because isn't the
If we
employment
put
manager
all
kind
of these
the manager, the HR
acronyms,
manager?
They got to join forces.
no, I'm sorry. This is starting to sound like Sesame Street. We've got the LBM, we've got the EBM, we've got the PBM, we've got the PBC. This podcast was brought to you by the letter B for bullshit. It's just like, oh my God, how many acronyms of these fools are they going to come up with?
I mean, it's really just a health economist circle jerk at this point. Like they love their market mechanisms and they love made up numbers.
For the younger listeners, we will not define that last term. That,
Jeff came back on. He just left immediately again. I'm sorry, Jeff.
He walked in the room. He walked out. Nice going, Jeremy. That's funny that you use Sesame Street, because I was thinking this would be like as if your star Jedi, decided like, you know what, screw this being on the good side of the force. I want to be rich. I want to have power. I want to send stormtroopers to their death. I'm going to the dark side. I'm fascinated that pharmacists would sell out and go to that side, but I can also, if you just look at who are we in this world? Most countries like ours are a capitalist type of economy. So maybe you did not go into pharmacy because you really wanted to take that vow of poverty. Maybe you actually wanted, to make some money. So what do? You just do the easy thing. And
Did you just say that pharmacy
doesn't want to be a
vow of poverty?
They do now.
They do now.
You're going to own a pharmacy. You're taking a vow of at least for a little while until you get it off the ground. I pay myself next to nothing.
Let's give them the benefit of the doubt, right? Let's assume, there were some pharmacists that did see legitimate opportunity here. That was untapped. They saw juice that had never been squeezed, right? If we can all buy into that, let's just buy into that. Okay. So let's assume that is the case. My concern now becomes, since in 2019 Senate Finance Committee hearings, we had major pharma executives attest firsthand that rebates and the extraction of rebate dollar value is actively driving up drug prices. The concern now becomes, if there's going to be a mad rush to tap into these historically untapped rebate dollars, what are the implications to list price? And consequently, what are the implications to patient out-of-pocket costs for these medications? Because in my world, we're not talking about $5, $10, even $100. We're talking about thousands of dollars per treatment, and patient cost share being potentially 20+% of thousands or sometimes tens of thousands of dollars per treatment.
Yes. And that is why I firmly believe rebates have to end.
They have to,
because I don't think they benefit anybody.
We'll agree. I mean, they benefit the people that it's benefiting.
You're right.
They make the shareholders of the major corporations awfully happy because the bottom line gets jacked. So, but
you couldn't be in the top 10 of Fortune 500 companies without rebate dollars. Period.
No, I don't think you could be. I don't. And it's crazy because it only benefits the insurers. It does, and this is the part that always makes my head want to explode, is where they do write those checks back to the self-insured plans. Those CFOs, and I know because I listened to one speak publicly about this, they think they are getting so much money. The one guy, I think I want to say his name is David Mitchell, and he had patients for affordable drugs. I think it was him.
It's David Mitchell. He's actually come around a little bit more. I'm no longer blocked. I was listening to him talk about being a CFO and managing a self-funded plan, and how when he first was approached with the idea of getting rebates, he was like, he thought it would be like a few $100s here and there because they had so many employees. And then he was getting these checks that were $5-figure, $30,000, $50,000. And it's unrestricted money. It comes back and it looks so good, right? But I have always asked the question, as compared to what, right? So if you're getting $30,000, $50,000, that's great. But as compared to what? The $100,000 you probably should be getting back.
Sucked out of the system. Yeah.
To your point, the impact on the patient is so bad, because we as the patients, we're the ones that are left with the list price. The list price is the price that's what's left over after. Lauren's joining us, everybody. But then here
Hi,
we are,
Lauren.
and we are the ones who are getting our deductibles, are based on what we pay at the pharmacy counter, which is based on list price. It's frustrating, and I think patients really, really, really get harmed by that. But now I'm going to step off my soapbox. Say hi to
They
Lauren,
do.
everybody.
Hey,
Lauren.
Hi, Lauren.
How are ya?
How did it go with your Pioneer software update?
What a perfect evening for a happy hour.
Wait, did you
So you're
switch
saying
over to
you need a
Pioneer?
drink?
We had a central server hard drive swap out the other day with Pioneer, and something
Didn't go well.
something got forgotten, and we found out about it. And we fixed it.
And how many hours did that fix take?
Well, it is still daylight here, so that's positive.
Oh, no.
Wow.
So did you get it resolved?
Hallelujah, we sure did.
Great.
That's right.
We
I
started
guess-
off the conversation talking about all the technology breakdowns this week. So sorry that happened, Lauren, but I think it's going around too.
Yeah.
It's okay. ESI is going to reimburse you for that now. They promise. For your time that you have to stay up.
As long as I am not affiliated with anything else that could possibly help me save money, right? That's the rule.
Yeah, as long as you're not making profits, you're in a good position. Otherwise,
Oh, and if there's a pharmacy within 10 miles, then you're not eligible.
I know, 10 miles. Have they been to a rural area, especially in the mountains? You know how far 10 miles is between pharmacies, especially in the hills, where if you go by like a geographic map and you go 10 miles out, you've hit 3 towns. But guess what the driving is like between all of that? No, it's just more of their bullshit.
Yeah. So for people listening, if you didn't see this, today was the day when Express Scripts put out some release announcing that they were going to have better reimbursement rates for independent pharmacies in rural areas if they had an Express Scripts patient that was 10 miles or more away from a pharmacy. Is that right? Did I get that right?
It was 10 if there wasn't a pharmacy within 10 miles. And the thing is the way the topography is, you're going to have a lot of pharmacies within 10 miles of one another, but there's going to be a lot of patients in between. Now, it's going to help a lot of pharmacy deserts where like you're in the Midwest and there's a bunch of going. But the thing is when it comes down to networks and they're claiming, oh, we got this in network, we got that in network. Whenever you have a 10-mile space out in like a mountainous area, they're going to claim, oh, well, you got 10 pharmacies or you've got 2 pharmacies within 10 miles of each other. We don't have to give them this better contract. Or we may have to shift them over to the mail order contract, which will be their big thing. Is they'll push mail order because there's multiple pharmacies within that area. Therefore, they can not define that as a rural pharmacy. And I can tell you that my family's pharmacy in Hayside, Virginia, in Dixon County, the last county in the United States to ever have a stoplight, is very rural.
I'm sorry.
So it's just more of their bullshit.
Quick fact check.
Last
Fact
one?
check. The last county in the U.S. to have a stoplight.
We were a Jeopardy question.
Oh, wow.
We were the only county in the United States to not have a stoplight. Now we do in Glenwood.
Congratulations.
Yeah.
Do you like that stoplight? Is it?
They made progress. That's where I'm from, folks.
Well, no, one of the things about that announcement that really struck me, and I actually pulled this up because I wanted to make sure I had it properly. Modern Healthcare quoted the president of Express Scripts as saying, physicians don't practice in these locations. And this is why they're doing it, because they care so much.
They were
1 in
pushing
5
clinical.
Americans live in rural areas, yet less than 10% of physicians practice in those locations. So that's why it creates critical access gaps, and independent pharmacists can close those gaps. Good. Well, you know what? Yes, they can. But if you run them out of business, no, they can't.
They're
It's
trying
just-
to push more of the make us do more work for less pay at that point, and to try to
I
squeeze
thought they
out
were-
a lot of the other people in network, like our mid-level and our physician providers. They're trying to squeeze them out. It's all a part of their fucking game. That's
Brian,
all it is.
I have a question for you. So with the infusion centers, those are I think not as common as pharmacies. So the patients that would go to an infusion center, or maybe I think you represent non-hospital infusion centers, right?
Correct. Non-hospital, non-oncology. Yep.
Yeah. Okay. So I am just, as we're talking about pharmacy deserts, I've got to imagine that this is a real issue for the patients that go to your centers for their treatments, right? Like they 10 miles minimum probably is something some of these folks would be driving.
Yeah, easily. Even in some major metropolitan markets, patients are driving 10 miles to get to an infusion center. I mean, they're densely populated in major metropolitan markets, but they're generally located in affluent communities with well-insured patients just because reimbursement rates are so abysmal. And that's the only way they can make the economics work. I mean, most infusion centers across the country cannot support a full Medicaid patient. Many cannot support dual eligible patients anymore just because of reimbursements. So yeah, transportation barriers are absolutely a problem. And the more rural you are, the more exacerbated those transportation barriers get.
Yeah, see, that's something I really wish that we could get across to policymakers when they're looking at, pharmacy benefit managers and all of the things that go on here. Because I think when I think of all the different modalities for pharmacy, and I think about the infusion centers, that is the one that really breaks my heart, because I know that, so many of these patients are probably, as you said, these are located in affluent areas, but so many of these patients are not affluent. These patients are, after talking with you, one of the things that I learned was I was always like, why can't patients just show up at the Capitol, right? And you and I got to talking about how much energy it takes to just be able to even get out the door, let alone go to an intimidating, place like a state capitol to testify. That got me to thinking more and more about like, what are the needs of these patients and how hard it must be when they get screwed around by PBMs with white bagging, brown bagging. And then you have these pharmacies these infusion centers, I should say, who are, really trying to provide this care, and then they are getting these massive hindrances to even to be able to help these patients. It's like it's such a lose for a group of people for whom they didn't ask for this. It's not their fault.
Oh, absolutely. They just want to do the right thing for the people that are getting hosed by the system, right? People with the craziest, most intense burdens of disease that just want their life back. They just want to be able to button their shirt by themselves in the morning, right? Get dressed and live their life without somebody helping them every step of the way. Play with their kids, right? Go to their spouse's Christmas party. Things a lot that most of us really take for granted.
No, I'm so glad that you say that. And then earlier when you were talking about the rebates and how much money gets made from there, it's really shocking for anyone who's listening to our discussion tonight. It's really shocking when you start to look at the cost of some treatments, and they are more expensive, and there's reasons for that. But then there's this percentage-based kickback that these middlemen who do nothing except get in the way get for the privilege of administering a benefit. It's really, I don't know, it's crazy making to me, I should say.
Oh, I was going to ask y'all, what did y'all think about Ron Wyden and everyone's like framework that they came out with? Like,
it was good. The Senate Finance Committee talking about the legislation they want to introduce. Yeah, I was actually just about to bring that up, Jeremy.
Oh, well, we had a lot of things happen this week, and we've also been having a good time. But I am trying to bring some things up.
Gold star, Jeremy. Gold star. Way to go.
No, but that, like, it seemed good. It's going to be multiple bills to get any of it done. But also, one issue I'm having is they dance around so much about it. Like, we get mentioned a little bit, but it's like they're dancing around reimbursement. Like, no one wants to come out and just straight up say, we're not getting paid enough on our end. And no one wants to do it because I guess the lawmakers think that sounds bad, but we really do. Like, reimbursement is one of the biggest problems, and that's not truly addressed like directly in it. And yes, I want my patients to pay nothing, especially with these giant conglomerates making a fortune. What was it? 29 billion last quarter of the healthcare conglomerates, the top 6 altogether, 29 billion in profits. And we're getting paid next to shit. Patients are going without care, and they're making 29 billion a quarter. Like, we have to address all this, top to bottom.
I would say the system is definitely unbalanced. I'm super excited to see the Senate Finance Committee pick back up on where they were in 2019. I know they had several more committee hearings planned, but then COVID hit. So I'm excited to see Wyden pick this back up. And I think this is probably the best chance we're going to have at getting any reasonable and meaningful momentum at the federal level.
This is our peak right now. We have the most momentum ever. That's why we need everyone out in force. Because
Agreed.
We're not going to get this again. It's too complex. People aren't going to get it. They're not going to get behind it. We're not going to have this again. We absolutely need to have everyone pushing full force right now.
Yeah. With the ProPublica article and the Washington Post article that came out over the last several weeks.
Yep.
I mean, it's the environment is as ripe as it's ever been or ever will be, probably.
How long did it take us just to get people to quit focusing on the manufacturers to focus on PBMs? How long did it take us? Like, just a few years ago, we were just like, what do we have to do? And then now it's just like things clicked. It's not going to stay clicked forever. You know how it is. You pass some legislation, people are like, well, we already did this. So, on to the next thing. And what was it just a few years ago where we talked to the advisor that was talking about, like, you all are never going to get things done unless you have people mad. Mm-hmm. And unless they're giving like fire to the actual lawmakers. We got that done. We can't waste it. And that's why we can't half-ass it.
So, Brian, that brings up a good question. Since you are not a pharmacist, how can we, as PUTT members and people listening, get other providers that deal with patients to start getting louder? Like, I know their frustration is every bit as high as a lot of the owners that we deal with, but what is the tipping point that you see for
sharing story? I mean, most of my members, especially the newer ones that have come to the market, don't know what independent pharmacists have gone through with PBMs. They haven't been in the market when you guys went through these battles and lost terribly.
Oh, we lost.
They just don't know what they don't know. So, I mean, that's one thing is staying diligent and keeping your voices front and center is absolutely critical, because the healthcare system cannot afford a repeat of what's happened to independent pharmacy. Period. Yeah. It's not going to help us with what happened to you guys and what you guys have gone through. But at the very least, you guys could help us, hopefully, maybe, possibly, contain the fallout of what's still to come.
Yeah. People still see us as like some, like, I don't know, like fighting off a horde of invaders. In reality, we're the resistance group at this point. We're more like the New Republic in Star Wars. Not even the New Republic, the Rebellion. Like, we fail. We lost. And there's just only so many of us left. And now we're just trying to take it back. And we don't want the rest of y'all to go through what we went through. Mm-hmm. And we warned physicians, we warned everyone for so long. And now they're coming knocking down everyone's door. And now everyone's suddenly concerned. We did say this was going to happen.
Oh, yeah. Those Optum payday loans that are coming out there.
Optum payday loans.
Oh, my gosh. If providers...
They'll take out of your reimbursement later.
Yes. Maybe that's going to be the catalyst that gets more providers, to stand with us.
If it's not rebate aggregators that totally blow up in their face, it probably will be. But I think now is the time, because one of the things we've been talking about, Lauren, is how there's this massive carrot, not candle. It's a carrot, edible vegetable, not
edible
device for elimination.
Are candles not edible? I've often wondered.
I suppose they could be not advisable, maybe.
And there's also enough physicians that aren't bought out by United Health yet, because their takeover's gonna be complete soon. We have to push now, otherwise they own everything.
Oh yeah, from payer all the way down to beneficiary.
Yep.
Brian, I know you have to get going soon. I think what would be amazing for our happy hour is on the topic of the pharmacies that kind of are looking at how they can at least get something by going over to the dark side and participating in these rebate aggregators. What would you say is the antidote to that? Like what from your view needs to happen?
I don't know. I don't know what it is, but if there's any prospect of raking in unfathomable dollars, it's going to be an uphill battle. That's what I know.
I tell you what it is. Public shaming. Full on, every single one of us. And we need to do this with all the docs that work for insurance companies, especially for prior authorizations. We need to do this for every fucking pharmacist that sells out. We need to do this for everyone that works for them. Top to bottom, we have to shame them for actually existing in that space. And we have to quit being nice about it, being like, oh, well, you're in that. Well, I don't agree with what you do. No, fuck them.
Or, hear me out. What
Together.
we could do is we could make sure pharmacies are adequately reimbursed for the services they provide so that they're not tempted to go over to the rebate aggregator side.
You know what's the funny thing about it? PBMs and all of them right now, they would not be facing any of this scrutiny if they wouldn't have fucked us over so much, because no one would know about it. There'd be people like us out here being like, no, patients are getting fucked. Like, everyone's getting fucked. There'd be people like us because we're us. But most of the rest of them would be kind of quiet about it because they were making money. They didn't even bother to pay people off because they thought we were so minuscule. And then all those people are saying, no, fuck this guy. He's ruined our entire livelihood. They're doing all this.
It just goes to show you cannot mess with independent pharmacies.
Especially when they come together.
Mm-hmm.
Yes, exactly. They all came
Well,
together.
and since this is Cinco de Mayo episode, I did a little homework. Apparently the French troops were shot back by it says repulsed in Britannica, by a much smaller Mexican force. The smaller force actually won the battle. So that's what we are.
Yeah.
We're the smaller
I
force.
love the French, and I love what they do because they will not have their civil rights taken away, and you will give them what they want. They keep their politicians in check, but they are not the most intimidating whenever it comes to war.
No.
No, they are not. And I think on
but
that
they're
note,
general people. Hats off to you.
Lauren,
You know what
do
to
you think?
let's Lauren have our last thought for the podcast tonight, and then we shall clink glasses and say goodnight.
I am all for the smaller coalition of independent pharmacy owners and friends of, in our group, allies, really just kicking the PBM's asses. I think we do just bring back the guillotine, Jeremy. I think that's what we do. French.
I would love to bring back the guillotine.
There we go.
The French people are awesome. The French military is not very intimidating.
Hashtag guillotine.
United for truth and transparency.
Cheers to that.
Cheers to that.
The guillotines.
Sorry, I was mobbed by dogs. Oh, there they go barking again. All the dogs weigh in and they say, cheers. All right,
Well, thank you all
thank
for having me again. This is always a fun pleasure.
Brian, I followed you on social media after your first appearance on our podcasts, and I fully intend to throw out all of my wonderful ideas on social media for how we can continue to support infusion centers and get your patients and your providers on board with our mission.
Absolutely.
Awesome.
All right, everybody. Well, thanks for coming together tonight and for celebrating Cinco de Mayo. I know we will get together again next month. Brian, I hope you can join us. It's always great to have you. So you're welcome anytime.
Perfect. Love that.
All right, everybody. Well, we shall say goodnight.
Cheers, everyone.
See y'all.
To learn more about Pharmacists United for Truth and Transparency and how you can help fight PBM abuse of our healthcare system, visit our website at truth